to become a visual retinal surgeon. So I think it's going to be a great day, and we're going to remember this for a long time. So please, in the chat, we will love to hear where you guys are from. Hamed Yusuf, hi from Uganda. Oh, so nice to have, the first two people from Uganda, from New York. We're in Latin America. We have all this amazing team. Dr. Williams is from, it's in Hong Kong, Dominican Republic. And then when you see this is when you start realizing that this technology, maybe we had to stay a couple of months at home, but now we are so close together, right? Those frontiers are done, are completely done. People from Bucaramanga, great to have you guys. I hope everybody's telling us where they're from. And I think it's an amazing topic. It's a topic we're going to learn a lot. So welcome to the virtual class from Ophthalmo University. For those who are not familiar with the platform, we have a new logo, we have a new look and feel, and that logo, sorry, I think it's Andres that it's new in, no, somebody's would be open. Okay, so new logo that says a lot, right? We used to have a logo with a book, and people say, guys, you are a digital platform. What are you doing with a book there, right? So we have this new logo with new colors, and it's more modern, more digital. The O and the U together, as you can see that. The Ophthalmo University. People see an eye there when they get together. I see a lens, right? I'm a cataract surgeon, so I have a lot to learn from these guys now about retina, and that's also like a quality, something you can put on. So we want quality information here in Ophthalmo University. What is Ophthalmo University? It's an ecosystem, right? It's an open source platform. You can plug in any ideas you have, so you can we can learn from each other, and we can be stronger together. I think that's very, very important. Social media, our communication channel, please follow us in Instagram, Facebook, LinkedIn, Twitter. Actually, we created a LinkedIn group that I think it's very, very interesting and a very good tool to learn a lot from each other. So when you get into, as I said before, Facebook, Twitter, Instagram to communicate, LinkedIn, there you have the group. I hope you can join us and share your experience and your knowledge. And the YouTube channel, we're going to be live in YouTube today too. And it's a virtual platform, a virtual library. You can enter anytime, and especially I think this specific topic, we're gonna come back many times to this talk and learn a lot from these colleagues. This is gonna be English and Spanish. I put it in Spanish, but remember, guys, it's gonna be in English as well. And tomorrow we have Fake It to the Limit. And look at these guys. If you're from Latin America, I'm sure you know all these amazing surgeons. If you're not from Latin America, you definitely need to join us tomorrow, because there are going to be amazing cases. We're going to go from non-ophthalmos to high myopia to cellular dialysis to all the cases there into the limit. So it's going to be very, very good. And people from Chile, like Andreas too, that we love to have. Well, Miguel Strur too. So Chile is present a lot in OU, right, Andreas? Then on Friday, we love this kind of talk. We're going to talk about how to publish in 5 steps for free in 1 hour. We love this kind of challenge. Everybody should be able to publish, to do so, to know how to do an article and how to publish. Lisandro, I don't know if you have a couple of comments about it, but you're really into this.
I won't miss it. That's it.
Great. I'm in a few words, but strong words. On Saturday, this is a passion of me, and controversial topic. Probably Dr. Liam that was in Canada. It's more used to this topic and talk about it. But in Latin America, actually, when we talk about bilateral cataract surgery in the same time, everybody gets scared. Everybody says endophthalmitis. No. But there is so many people in the world with amazing evidence, special, as everybody knows, Steve Arsenault, right? And Thomas Oeting, two amazing surgeons who are going to talk about this. But I think the key here, the key ingredient is even better because we're going to have Daniel Turvin and Quinn Guang. There are two young surgeons in the US who are starting to do this kind of surgery in the US. So that's strong, right? To see two young surgeons starting to do this immediately sequential bilateral cataract surgery, and they're gonna share us their experience. So I think we're gonna learn a lot, and everybody can register. It's gonna be English and Spanish as well. So well, everything is set up. Welcome everybody. I wanna thank all panel, of course, but special thanks for Andreas. He's a great friend. He has been involved in education for a long time with the Orbis team. Somebody who is into simulation, into teaching. So it's an honor to finally have you here, Andreas.
Thank you so much, Ivo. For us, it's an honor to participate and do this amazing webinar. I'm hoping that everyone will have a lot of fun.
Great. So you can introduce the panel. We can start.
Yeah. I can share my screen, or because
Sure,
I have some
sure.
picture of him.
Sure.
Okay. Give me 1 sec. There you go. So guys, thank you so much for being here. Thank you so much to all the panel of experts that we have today. We have amazing surgeons. We have amazing young retina specialists. So today we're going to talk about basics and surgical tips in my first vitrectomy. So the objective of this webinar is to see all the steps of the vitrectomy surgery, analyze them as well, and see how we can avoid the nightmares during your first vitrectomy. So let's start. So we have here first Dr. Wai Chin Lam. He's one Orbis friend. He's an active retina specialist, and he has worked with us a long time. I think we worked together, I think it was in Mongolia. I'm not sure, Dr. Lam, but it's an honor to us to have you. He had a lot of experience in surgery, also in teaching. He was a long time in Canada working. Nowadays, he's in the University of Hong Kong and is an active member of Orbis. So thank you so much for being here. We have also here Eduardo Kenstelman. He's from Brazil. He's from Rio de Janeiro. He's also an amazing retina specialist. He's very friend of me, and I'm very happy to have you here. Then we have Dr. David Hedman. He is from Canada. He's from the University of Alberta. He's a brilliant young retina specialist, and is also very engaged with the research in retina. Then we have Shamfa Pert. She's from Jamaica. She just graduated for the Retina Fellowship. So I think she has a lot of things to teach us about the new things, about how was her first vitrectomy, how is nowadays her practice in Jamaica. So it's a very good to have you with us, Shama. Then we have Uriel Rubin. He's from Argentina, but he did all his academic education in Canada. He's working in the German hospital in Buenos Aires, and he also was part of the University of Alberta and Queen's University in Canada. Then we have Felipe Lucaro. He's from Salvador Bahia, Brazil. He's the CEO of this amazing Instagram. I mean, Retina Tips is amazing. I follow you. It's an amazing Instagram. You gave us a lot of tips every day. And he works in the Clínica Los Ojos, and he's part of the University of Sao Paulo. Then we have Alexander Gan. I had a lot of good references from here. He's a very young retina specialist, very brilliant, and we are very happy to have you with us in this panel of experts. So thank you so much, Alex, for being here. So let's start. So the discussion point, the things that we're going to discuss are first, virtual reality and simulation as a training tool. We know that it's very important to us to prepare before doing the first vitrectomy. So we will talk about how you do this in your workplaces. If you have a training center, how do you prepare your fellows before doing the first vitrectomy? Then we're going to start all the pre-considerations before starting the first vitrectomy. Then we are going to review all the steps of the surgery. We are going to discuss the most important steps and see how we can learn from them. And also I did a global interview. It was like a global survey. and I asked a lot of different experts all around the world about the 5 surgical tips. So I want to show you as well what I found doing this small research. And finally, we're going to review all these tips by one, all right? So let's start. So I think it's very important to think about the oh my gosh, because when we want to do the first surgery, we always have some questions, some doubts. Sometimes we're nervous. So sometimes you don't feel very confident, and it's normal. Sometimes you think, I have done so many cases. Sometimes, oh, the patient could hear that it's my first surgery, or my left or my right hand is kind of lazy. Or for example, oof, I need time, like eyes time, or I need more coordination to use all my senses, because we know that in vitrectomy surgery, we need to use all the senses, all the senses. So this is the oh my gosh effect. So what happened? So before the surgery, the stress and anxiety meter started increasing, and then boom, then we have explosion of emotion before doing our first surgery. And I think that's very normal. And I lived that before. And I think that we can share a lot of nice advices to avoid this anxiety or stress before doing your first vitrectomy. So the more important before doing any kind of surgery is prepare yourself. How you can do this? You can read about the techniques. You need to get familiar with your work environment. That means with your co-fellows, with your professors, with the nurses, with the anesthesiologists, with the whole team. It's, it's good to see videos as well. And nowadays, because thanks to the social networks, we have available a lot of webinars. We have a lot of telemedicine platforms, for example, like Cyberside. We have Ophthalmo University. And also in YouTube, you have available a lot of different video about different techniques. So now that you have read, you have seen some videos, you can start your training. And I think it's very important, be aware of your strength and think to improve it. Don't be aware of your weakness, be aware of your strength, because you will achieve it. You need just to do it. So I want to show you this because I have a lot of experience using virtual reality as a training tool before doing any surgery, for example, in cataracts and also in retina. So I think it's important to show that nowadays we have available virtual reality. For example, we can train gyloid detachment, we can train peripheral vitrectomies, ILM peeling, you can train removal of epiretinal membranes, and also you can do retinal detachment using oil or gas. So I want to show you some examples. We have from basic models to, for example, to learn how to see better, how to get better with your depth of field, or how to use the instruments inside the eye, because we know that the eye is not a circle. We have some angles, they have some special shape, and it's important to keep that in mind. So I want to show you this, for example, to practice your depth of field. You need to touch this red balloon like 1 second, and then the red balloon became green. If you touch the retina, you will damage it. And if you touch the lens during this, you will also see that. So it's very good for the beginner. And also you can train how to use the instruments in the posterior chamber, as you can see here. So we need to grab these squares and put it in this green bag, as you can see here in the example. Going more deep or going more to the surgical aspects of the simulation, you can practice, for example, I will show you here, one critical step when you're starting doing vitrectomy is the posterior gyloid removal. And this gives you a lot of freedom. You can do it with triamcinolone, you can do it without triamcinolone, you can move freely all the instrument inside the posterior pole, as you can see here. Now, here we are staining the posterior gyloid with triamcinolone to see better where it is. And then using just vacuum, we're going to detach it, as you can see in the video. We have also another examples. For example, here, I want to show you the ILM membrane peeling. You can do like a rhexis in the retina, as you can see there. Then you have the forceps, the ILM forceps, and you start doing the peeling of the membrane. You need to be very careful, because if you touch the retina, you will see like a red dot hemorrhage, like in real surgery. We have also more specific models, and I think it's very helpful to train yourself. For example, for retinal detachment, here we will see, here you can see the tear. We are going to inject PVC in the cavity just to flood the retina. And then we are going to use laser just to mark the lesion, and then you will see how continue. And at the end, you have the freedom to choose if you want to put silicone oil, if you want to put some gas, or if you want to put air. So it gives you a lot of freedom. And if you do this with a mentor, you can also train different techniques. So the first, and I also think it's very important to show you that there is some studies that have shown the construct validity of these training models. So I think it's an open window to all the young ophthalmologists to try to do more research in this area, because we don't have too much information, and this is the future in the training. So I think it's very important just to keep in mind that this can be very cost benefit if you have all these resources available. So now is the first discussion point. So guys, how do you prepare your fellows, your residents before doing the first vitrectomy? Do you have like a training program, wet lab, dry lab, simulation? What do you have in your workplaces?
So can I start?
Yes, sure.
So I think, well, I have already seen the, this virtual reality, but it's not affordable for every place. This is a problem. The machine is expensive, and it's difficult to have the machine in your clinic or one hospital. It's a good way to teach, but it's not for everywhere. So what I do is to let the fellow do parts of the vitrectomy. For instance, if I do vitreous hemorrhage, I allow him to do the PRP. Or if I'll do a macular hole, I leave him doing the vitrectomy, detect the hyalot, but I lift the ILM and he begins to do the, the rexes of the ILM. So I start to teach the fellow doing parts of the vitrectomy exactly like in a cataract surgery. In a cataract surgery, you let him put the IOL or put methylcellulose in the anterior chamber. You don't start doing the most difficult part of breaking the nucleus, for example, or peeling the epiretinal membrane. He starts to do the easier parts of the surgery, right? And then it depends on the train or the speed of each one, he will start to doing the other more difficult procedures. But essentially, I let him doing parts of the vitrectomy. And the best thing is to start with pseudophakic patients, because it's quite common for him to get lost inside the eye in the first 10, 12 cases. He doesn't know if he's going to the right and the foot pedal to the left and the biome is out of focus. So it's very common for him in the beginning to get lost when he's inside the eye. The illumination goes to one side, the vitreous curtain goes to the other side. So it takes a while for him to get used to the movements. So it's step by step. I don't let him doing the whole surgery, just the easiest part of the surgery. And it's good to have pseudophakic patients because it's not uncommon to touch the lenses when you're beginning.
Yeah, I totally agree what has been said. And I think like all surgical procedure that learner learn the step by step. They cannot really go right into it without having the opportunity to practice different part of the steps. And we are fortunate to have the simulator, the ISIS, both in Toronto and Hong Kong. So we do have a program similar to what you have shown to practice the dexterity, practice the maneuvering of instruments, so that they do have to go through those training courses before they can practice in the real patients. But if you don't have the simulator, you can also have other forms of wet lab, such as the pig's eye or the cow's eye, that you can at least get the familiarity with the instrumentation inside the eye and how to use the microscope. But I totally agree. I think it's important to get familiar with your instruments, particularly the microscope and the vitrectomy, and knowing how the instrument move under the microscope, and then how having a feeling of the instrument working with the light pipe, how to illuminate and translumate the vitreous. And I always reminded the fellows is that you cannot do any vitrectomy if you can't see an instrument. So you have to have both instruments in view, because the minute you don't see the instrument is the time that you get into trouble. But I totally agree what Eduardo have said in terms of gradually, even if you go through those training exercises, you still have to develop the skill gradually, step by step.
I would like to add something. Yeah, so I haven't had access to posterior segment simulators, but I had access to anterior segment simulators. So one of the advantages that these simulators give you is that you can train your non-dominant hand. So by the time you start doing surgery, your non-dominant hand gets easy flowing through the surgery. And the other thing is, like when doing simulators, like simulated surgery, you can see the consequences in the simulator of every mistake you do. It's not like when you do this sequential training that Dr. Kenstelman was saying about. Every time you do a mistake, your trainer takes care of taking care of the complication you do on the eye. But if you do the complication in the simulator, you just can see the consequence of that complication you just made. So I believe those things are gonna give you some advantages in your training curve.
I can add one more thing, if you don't mind. I think that even before doing a vitrectomy, when I don't train fellows yet, but I have like a few residents that I somehow train, and I think it's key the view, right? So they have to grab the microscope with one hand, being inside the eye with the light, making sure that the light pipe is not going very deep. So I think that even before starting using the cutter, I think that making the correct view is key for like the next first steps.
I agree. I totally agree with that. I think in the beginning, the most problem that we have to troubleshoot is visualization, depth, orientation. Know how you can move inside the eye, and access to the periphery. How can I go to the periphery safely? And it's the key points in the beginning to the fellow to learn.
Andreas, can I add something?
Services here.
Yes, of course, my friend. Feel free.
Sorry.
How many
no,
services here in the panel have a simulator?
Sorry, can you repeat the question
How
again?
many?
Who has a simulator in the panel?
Okay, so we do have one in Orbis, and we do have one here
I
at
know.
Mexico.
In Mexico, in service, you have a simulator like that.
Yes, we have one, and it's
I don't
very
think in Brazil, maybe in São Paulo, one. No, I don't think, Felipe, we have in Brazil one service with a posterior simulator.
No, not yet in the
Not
Federal University of São Paulo. There's some researchers that have the contact and publishing something about the simulators, but it's not.
You don't have it practice.
Used in the training of the fellows yet.
Okay.
So it's something. It's the ideal, but it's not. I mean, quite practical.
It's really nice. It could help to win a lot of obstacles in the beginning. I think, but it's not accessible.
Okay, so I will move. So it's
Can I add something, Andres, very
yes,
quick?
Ivo, please, go ahead.
I think this will add some spice to the discussion.
Okay.
I'm a cataract surgeon. I love cataract surgeon, and I definitely don't want to become a retina surgeon. You have a different life, different patient, different surgery. So it's not my idea to become a retina surgeon. But in the institution that I have, I have a posterior simulator. So I said, why not? Let's try it. Let's see what are the key difference with the retina. And the most important things here, there's three things you guys are talking about already, but I will love you in the entire presentation to talk about. The first thing I sense is the distances. You guys work in long distances, so it's not easy, right, to see perfectly all the time. So you need to play a lot with the microscope, right, to go up and then down to the retina. I think that's a very important key for somebody who's learning, right? That was my sense. The second one, somebody said it in the panel. I think it was Alexander about your not dominant hand. You know, I tried to, the simulator made me train my left hand, and I was like, wow, do I need to do everything with the left hand now? Why? So you guys need to be good at both hands. That's very interesting. The third thing was like, I used to, you know, I was doing something with my right hand. I need to illuminate with my left. And then suddenly I'm illuminating something extra. It's not the thing I need to illuminate. That was another thing I struggle a lot. And the fourth thing is about, I like a still eye when I'm doing phaco. And here I had to move the eye to reach places, right? So I think in those four things, you know, even for a microsurgeon, are very interesting secrets. And the last one, and one of my favorites, then I can show a slide if you let me, Andreas. But
yes, please, please.
And I think it will be very important. This is done for phaco, but I'm sure it's done for retina as well. And it's very, very important. It's about, you know, surgery. You guys are expert. You already know this. It's not only about motor skills and moving your hands, right? It's about the decision making. And you guys in retina, it's seriously, it's a completely different story. In a phaco emulsification, I know what to do and what's coming, and it can change. But then here you guys is, okay, I'm doing this. And if the eye behaves like that, then I'm doing that. So I guess the decision-making process for a retina surgeon is also very, very, demanding, and you need to struggle a lot. Sorry, I wanted to do that, you know, as somebody who experienced simulation and didn't know anything about it, and they were very interesting topics, right?
Yeah.
Ivo, you listed all the reasons that we retina surgeons are better surgeons than the phaco surgeons.
You're right. You're right. You're right. No, but again, seriously, it's a completely different surgery. But I have seen so many retina surgeons that, oh, I have a multifocal. Please do the surgery, you right, or the toric. But you're right. You guys have a very hard job.
We take the cataract just to start the retina surgery.
Okay, so I will move out. Okay, so it all starts before the surgery. So surgery begins, of course, with the patient first consultation. So you need to identify the diagnosis, the comorbidities. You have to do an adequate diagnosis. And it's very important always to lean on your colleagues. Always ask to a professor, to someone who has more experience, because at the beginning we have a lot of doubts. It's also very important to document all your cases with a lot of imaging. If you have available the optos, the OCT, the angiography, try to do it. This will be very helpful to do the follow-up and to plan the surgical decision that you will make. And always very important, the teamwork. Discuss your surgical plan with your more experienced colleagues. The eye see only that the eye know. Talk to the anesthesiologist and document what type of anesthesia you're going to use and what is the surgical time. Because remember, anesthesiologists are our allies in vitrectomy surgery. Your assistant must know what type of surgery is, and with it, check the equipment to be used. So I want to show you this mission possible that we made. So the mission was find the most important surgical tips in vitrectomy. We accept the mission. And the objectives of the mission was ask to fellows, young retina specialists, senior retina specialists about their 5 steps in your first vitrectomy. And then after doing that, discuss with you guys, the experts, about them. So we took a journey all around the world. We started in Chile, then we asked some people in Argentina, then we moved to Brazil, then we went to Venezuela, then to Mexico, US, and Canada. And in this first journey, we asked about 12 retina fellows, 4 young retina specialists, and 6 like very experienced retina specialists. Then we move out to Europe because we want to see what they do, or what they think about these 5 surgical tips. So we went to Spain, we went to France, then we moved to Cameroon. So we asked some people from France, from Cameroon, about the 5 surgical tips. And then we moved to India because we know that they have a lot of experience in high volume surgery. So we also asked them about the 5 surgical tips. So in Europe and Africa, we talked with 6 fellows, with 4 retina young specialists, and with 5 retina specialists. And in Asia, this is the number. So finally, we got all these people and more. So thank you so much to all these other surgeons that helped me doing and collecting all these tips. Also, I had some help from my co-fellows from Retina, from APEC, so you can see them all together. And this is what we find. So the first one was ergonomics, because it's very important in any kind of surgery. You need to be comfortable. Then we found that pure the infusion cannula and also verify the location of the infusion cannula is one of the most important tips when you're starting the first vitrectomy. Then we have a good position of the trocars. We knew that is also very important. Then check your settings before the surgery, just to make sure that your vitrectomy machine is working well, because you never know who was before you. Then the other point was have a good visualization. So always keep the cornea hydrated. Then, of course, do not cross your instrument in fake patients. Then about the central vitrectomy, they told me that use the optic nerve as reference, and if you can, in a vitreous hemorrhage, try to do the central vitrectomy without the biome. The galidectomy, a critical step in the surgery. If you're not sure, use triamcinolone. Then always check and make sure that you have done and indent the periphery 360 degrees and do the shape carefully. And always light up your work plane using the shadow of the instruments as a reference point. So now we're going to discuss all these points. So first, which are your tips, advice to stay comfortable during surgery? Because sometimes, you know, we have to do a surgery and we can be like 2 or maybe 3 hours during the procedure. So what are your tips to stay comfortable? Or what about the ergonomics doing a vitrectomy?
I think the anxiety you said in the beginning, maybe the fellows in the first surgeries neglect these steps, and it's very important to adjust your seat or to adjust your interpupillary distance before the surgery. Place all the foot pedals in a good distance for you. It's really important to set everything after before the surgery.
I think it takes a while. Like I remember seeing my co-fellows, like they were measuring kind of the attitude of the hips to the head of the patient, and they were doing this and that, and I was okay, and I was just sit and do surgery. So I think that it took me like quite a fair amount of surgeries until I realized which were my best ergonomics. So I think it takes time, but as you mentioned before, it's very, very important to be comfortable, because you never know how long it will take a surgery. Maybe you think it was going to be a half an hour and it ended up like 2 hours. So it is important, but I think the only thing that I can say that it may take a little bit.
Yeah, spending that extra minute at the beginning of the case is a very good investment in your time, and I think it can eventually lead to more efficient surgery because you're not having to reposition. So I think that's really important to remember. And then if you don't, I mean, it won't be long until your back, your neck forces you to address this issue because, as you know, like it's not a natural position to look through that scope. So this really needs to be paid attention to if you want to have a long, healthy career.
Maybe schedule just one surgery at a time. Don't schedule 2 or 3 because they might take longer. And I always tell the fellows to fix the head of the patients and look at the eye, because sometimes the eye, you fix the head and the eye is a little bit out or in, it's exotropia or inside because of the anesthesia. And to fix the head with the eye parallel to the microscope. So when you put the biome or the Volk or a contact lens, the focus is in one place at a time. It doesn't make different focus inside the eye. So the fellows are always stressful in the first surgery. Talk with them, and I think what I do is to let them do parts of the surgery as they are working with me. If I do, for example, vitreous hemorrhage, they do the PRP, or they first remove all silicone oil. So you have to keep them with a safe mind, like tranquil.
Yeah, I agree with all the things that was said, and particularly when if you have another surgeon, like the senior surgeon, be your assistant or mentoring, and when you switch, sometimes you say, "Oh, I will just kind of adapt to it," and the positions or the. I think take that extra moment to making yourself comfortable when you switch in the middle of the case is important. Never compromise what you have to do, and just making sure the eyepieces, the position of the microscope, the foot pedal on the sturdy floor and is reachable, and the laser foot pedal should be over near the vitrectomy pedal, so that you still have your control of the microscope, so that you don't have this using the same foot controlling the microscope and the foot pedal of the laser. So things of that making life a lot easier. And don't compromise, even though you have a senior surgeon operating with you and you're switching, you have to change everything. I think it's worth that extra moment.
So I will also add to like adjust the height, not only of the seat, but also of the armrest. So, and also make a checklist before surgery of all the things that you might be using during the surgery. So by the time you ask for something, it's on the tray already.
Also related to staying comfortable is remembering to stay hydrated, have snacks between cases so you're feeling good, and monitoring the temperature of the room. I prefer to operate in a colder OR. I don't really like it when it gets hot, so I pay attention to that too throughout my day.
That's why you're Canadian.
Yeah, we like it cold.
So I don't know you guys, but I always think that doing a vitrectomy is like being a drummer, because you need to use all your senses. Like, let me show you, for example, here. You need, of course, both eyes, hands. Sometimes you need to use more than 3 or 4 trocars. You have to use your feet. Then you have the pedals. You have the microscope. Sometimes you have the laser a part of the vitrector. You have to use also to do the vitrectomy. So there is a lot of things that we need to be aware when we are doing vitrectomy. So I have here a video from Felipe. Can you want to tell us about this?
Yes, this video tells us tips about the position. It's another thing. Before the surgery, it's important to program where you will place your instruments. We are talking about the ergonomics and the comfort for us, but it's important also think in the comfort for the patient, because most of the time we are doing local anesthesia, and maybe something in the hair can be uncomfortable for the patient during the surgery, and he feels necessity of change the head position. And we always have to check the anesthesia before start the surgery, because if the patient had some rectus muscle moving yet, it's important to complement the anesthesia, and you can tolerate only intorsion or extortion, or the patient will feel pain during the surgery. This video tells us about the correct position of our trocars.
Okay, let me just put play.
Yeah, because patients who has a front, prominent front, maybe in the nasal point, it could be a difficult for us. So I use the temporal trocar at 9 or 3 o'clock, depending on the eye. And the nasal, I put in the 45 degrees, putting 2 or 10 o'clock. So I can entorse and extort the eye to assess best the periphery during the surgery. I can see well the periphery doing this movement during the surgery.
Perfect. So now we're going to talk about the perk of the infusion cannula and verify the location. So how do you guys do this in your surgery? Like here in this diagram, like in the video, or you have another technique? And why do you think that is so important to verify the location of the cannula before starting the surgery?
Well, you must do this so you don't infuse in the subretinal space, in the suprachoroidal. You don't create a choroidal detachment, and this. You start it in a wrong way, and we always check if the cannula is okay. About the place, or if it's 3 o'clock, if it's more, it depends on the surgeon. Some surgeons like to do surgery with the arms very wide open, and some like to do. It's like, for example, if you do a phaco, the auxiliary chopper. Some people like to do a 90 degrees from the incision, some 45. It depends on the way the surgeon feels more confident, more it's better for him. So I think there is not a right place. You can do it like you can do for you, and tell the fellow to start the surgery, and as with practice, he can put in another place, or it depends on where he feels more comfortable. But we should always check if the infusion cannula is in the place.
And just adding to what Eduardo said there, with regards to trocar placement, sometimes the eye might have a supratemporal tube or a trab. Other things you're going to have to be aware of and you have to avoid. So sometimes you have to adjust your trocar position for that purpose.
I have a tip in this step, Andreas. Can I?
Yeah.
I use constellation system, and always we start the infusion, and we lock the key, and then we put in the infratemporal trocar the infusion. We check, and then we turn it on. Okay, but always there's a bubble in the beginning of the surgery when you do these steps that turn it difficult, the surgery in the beginning, the curvitrectomy. What I do, I turn the infusion one, and instead of close the key of the infusion line, I just press with my fingers and interrupt the fluid with my fingers. I place in the trocar, check the position, and while I'm watching the tip of my infusion, I just leave it. So I can avoid this bubble in the beginning of the surgery, and I can not only check, but check while I'm turning the infusion one. I think it is important.
You always have to check from the outside, like with the light probe.
Just turning my head, and maybe sometimes you can use
And for
an
example,
instrument.
if you put the cannula in one position, how do you handle it? You
Excuse
remove
me?
it, you change the position of your infusion. What do you do when you have, for example, a subretinal position of your cannula?
I used to turn it off and maybe to put in another quadrant in the case of a choroidal detachment, located choroidal detachment, or even in the anterior chamber if necessary, as a anterior chamber maintainer. But it's important you to remove it and change the position so you can increase the IOP, and then you can back and place in the correct position.
I think if you have situation when the tip is not visualized, you should look at the reason for it. As been mentioned, if this is hypotony, or is it choroidal, or is it anterior PVR that is blocking the tip. So if it's hypotony, you can actually take a 30 gauge needle and get some BSS, and then put the needle in, and you can visualize it in the microscope is inside the vitreous cavity, inflate the eye, and that can make the eye firm so that you can put the choker in properly. If it's choroidal, I would do what has been suggested, but repositioned to another place where there's probably less choroidal, but enter the choker in a more perpendicular direction so that you don't do this oblique entry, so that you shorten, so you can penetrate through the thickened choroid easier. But if the eye is soft, if you may not want to take the choker out right away, you can put the pressure into the eye, and it actually allows to drainage of the choroidal. And then when you put this, replace the choker into the eye, you may have an easier entry. But if it's retina, then you're in trouble because of the anterior placement of the displacement of the retina. Then you may have to go through the anterior chamber to get access, because depending whether all the position that you have could be blocked by the anterior displaced retina. Another trick that has been useful is that you can, if the other, like if this happened in the middle of the case and not at the beginning, and you can swap the infusion line from the infusion to the other port where you have clear entry. Because sometimes during the surgery, the cannula may have moved and the tip of the cannula may retracted and become underneath the RPE, and you may have a progressive choroidal during the surgery. And the quickest things to do is to take the infusion cannula and place it to your superior sclerotomy cannula and bring the infusion back on. And then that actually also helped to drain the choroidal from the infusion cannula. So those are some of the tricks that you can do.
Okay, so now we move to the to the position of the trocars. As we know, it's very important. There is different techniques. So that's why I'm asking you guys if you have any technique or any recommendation to start putting the trocars. You always do it like in the same time, or you always put in the same position, or you have some different or special cases where you put it in another position?
I use the same position unless, like a friend here said, there is a track or a valve or some problems with the conjunctiva. Otherwise, I use put it on the same places, and I think each surgeon will find the best place for him. Maybe he has huge hands and he wants to operate with the trocators at 9 and 3. And some people like to operate closer. It's depend of each one. It's the way you feel better.
I think you just can avoid from 2 to 10, at least 2 and 10, the positions, because if you get too superiorly, the both of them, you have difficulty to assess the periphery in the superior periphery, to laser it and to shave it. So I think that the position here in the draw, 2 and 10, at least this position.
Yeah, I find if you go like 3 and 9, sometimes by mistake, I think that when you move, I don't know if you have the same issue. Like when you move, you create some corner faults, and that makes a little bit uncomfortable the view. So I usually go a little bit higher than 3 and 9.
What about the visualization? You have any technique, or for example, when you decide to do a desepithelialization of the cornea during the case?
So
Well,
I always check.
sometimes 30% of the time of the surgery is search of a good visualization sometimes. And I always tell the fellows, if you don't see, don't do it. Wherever you want to do it, you have to see well. So when you do when there is a corneal edema, I just in the beginning, before going inside the, well, not before, but it just in the, when I recognize corneal edema, I take the epithelium out. And that's, I do this quite frequently. When the surgery takes 1 hour, an hour and a half, quite frequently you have to do it.
There's another trick. Sorry.
Yeah.
Go ahead.
Yeah, sorry. Sometimes even before that, I mean, we typically start with OcuCoat on the cornea. And if I see that the epithelium is getting a little steamy, you can actually roll it with a wet Q-tip, and that detrigresses the cells. That buys you maybe that 5 minutes you needed to do the drain and get out of the eye. So I'll do that before I debride the epithelium.
Actually, I was going to say the same thing, except that I use a dry cotton applicator. And I find that like a squeegee, it dries up the corneal epithelium better. And then I put the gel right afterwards, and without putting any more BSS, because that will rehydrate the cornea. So instead of using a wet Q-tip, I use a dry Q-tip. I found it has a better drying effect of the corneal epithelium. And that works without have to take the epithelium off. But eventually, if the surgery go on for a while, that may not work, and then you may end up have to debride the epithelium.
So I will also suggest on like getting an idea of how the corneal status before the surgery is, because if you do a combined surgery and a phaco-vitrectomy, and you, for example, you don't have a lot of endothelial cells, and then you start working in the posterior pole, you have to take into account that factor, because if you're gonna like raise the pressure, there's gonna be a lot of edema in the cornea. So like take into account the corneal status and how high you go with the infusion pressure in the eye.
Mm-hmm. And also keeping in mind, if the view is going, I typically focus on getting the delicate steps of the surgery done first. So for example, if it's a phaco-vitrectomy for a macular hole or an ERM, I will go to peeling quite quickly after a very limited core and get the ICG in. Or if it's a bad PVR retinal detachment, again, I'll try to get the peeling done, as quick as I can while the view is still pristine, as opposed to having to do that later on in the case.
So now we're going to talk about the central vitrectomy. So do you guys have any tip about the settings of the machine, how to start, how you use the tip, of the position of the tip when you're doing the central vitrectomy?
I think in the beginning you have to see both of your instruments after to go deeper. It's interesting to do the vitrectomy under the cannulas in the first moment. So and try to keep a wide field illumination, not just in a focal point, but try to not enter a lot of with your end illumination in the beginning, so you take a best visualization, a better visualization.
Yeah, you certainly always want to be cutting in your cone light.
For surgeons, I tell them to go behind the lens and like going down, going up, like dancing behind the lens, so he can learn the movements. when he goes down, where does the foot, the microscope should go, and then left, and then, so he's walking with the light and the vitreous probe and trying to illuminate the point of the, well, the area where the vitreous cutter is, and moving the, you know, the microscope in the way it should. So this is like a beginning to feel that how do you move inside the eye? So this is something that I usually tell the fellow that is beginning.
Another thing I think that fellows often need some reminding of is just to verticalize the light pipe when they're starting. A lot will come in shallow, but I find if you remind them to get used to verticalizing that light pipe, it provides a broader posterior illumination and safer, more efficient cutting.
Yeah, I think it's important to remember you're using a bimanual surgery here. You have the light pipe with the cutter, and very often people just kind of frozen their light pipe in one position and try to do the vitrectomy. It's important to keep moving the light pipe in a different direction to get the best view of the vitreous. In the case that's shown, there's vitreous hemorrhage is no problem. You can see the rest. And if you have Chime syndrome, you can see the rest. But otherwise, the light pipe should be dynamically moving because as you're moving a different part of the vitreous cavity, you need a different directions illuminations. The other thing that I find is that we all concerned about the instrumentation. So very often people just concentrated in doing the central core vitrectomy. But if you think about it, the starting of the vitrectomy should start more in the periphery than the center, because if you start at the very center, you pull the vitreous the longest distance. If you start more in the periphery, then you have least amount of tractions in the peripheral vitreous. That may take a bit more confidence before you start, because as been shown here, everybody start right in the middle. But if you start right in the middle, you create the most tractions for the vitreous, if you think about it. And but that will take time. I think once you get comfortable where you are, then the idea actually is not start at the very middle. You actually start in the periphery and then move centrally. And that's how you reduce peripheral tractions.
Another thing interesting in this video, Andreas, is fellows can use the shadow of your instrument to depth orientation. You know, when you're far away from the retina, your shadow is far away from your tip. And when you are closer to the retina, the shadow almost touch the point. It's a good reference to the fellows in the beginning.
And for example, do you guys use the optic nerve as reference when, for example, you're doing a vitrectomy in a very dense vitreous hemorrhage? Do you have any reference point when you're doing the vitrectomy, or you just start slowly and then you start going down, down, down as soon as the case is getting, how do you do that?
If there is a dense vitreous hemorrhage, I tell the fellow to go to not to the optic nerve, but at the equator, more or less, until he finds a break in the hyaloid. So then he goes like 360 following the break, because at the equator in general, it's easier to find the hyaloid detached. So you don't go in the direct, if there's a dense vitreous hemorrhage, you don't see the posterior pole, you don't go straight to the posterior pole, because if there's a traction retinal detachment, sometimes you just won't start the surgery making a huge break, or you're cutting the retina in the middle of the, you know, in the beginning of the surgery, and then the case is closed. You can't do anything else. So I tell the fellow to go to the equator, in general, to the side that he's holding the cutter, either if he's left-handed or right-handed. So he goes in the side that he's holding the cutter, he illuminates, and into the cutter in the equator, he goes the same. I tell him not to go moving around the cutter, to stay more or less the same place until he'll see a break in the posterior hyal. And then he goes like a capsulorhexis, more or less, yeah. Not exactly, but.
In a dense vitreous hemorrhage, I'll hang out behind, the lens as close as I can and slowly work my way back. But I think even more so important in those cases, it's really good. Like I really want to make sure that I've done the ultrasound myself preoperatively, so I'm confident that there's no RD. And I find in those cases, if I know I've done the B scan, within 24 hours, and I'm in that eye, I'll get much more aggressive and get more posteriorly a lot sooner than if it's a same day add-on and I don't really know the status of the retina. Then I'm really tentative and slowly working back from the lens.
I agree, and many of you said it before, like make sure that you are seeing the instrument, right? In this case, the cutter. Make sure that you're always seeing the cutter. And one thing that I don't know, is my opinion, that many times if you stay even at one point, like in the core vitrectomy, you stay a little bit, they are cutting, is the blood starting washing out, and you start having like a better view, even almost without moving deeper.
And what about the peripheral shaving? I know that it depends on the case that you're having. So what are your tips or advices during this step of the surgery?
Well, my tip is to leave the most difficult parts of the surgery for the fellow to the end. Don't start your surgery doing the difficult, what you think is the most difficult. Do everything what is easier, and then leave the most difficult parts at the end. In general, depending on the case, as I said, we go to the peripheral shaving to take slowly, watch the lens, if the patient is fake, tell the assistant. Some people do surgery with chandelier and they indent the eye. Some others they don't use, they tell the assistant to indent. So the ideal is to start doing peripheral shaving without vitreous hemorrhage, like in a macular hole or epiretina, because you see clearly the retina. If you are doing the peripheral shaving in a vitreous hemorrhage, sometimes you don't see where the retina is. So start doing in easiest case. That's my tip.
I think it's important to use high cut rates and low vacuum, and you can turn the mouth of the vitrector against the tear if you need. I think for the fellows in the beginning, it's critical to use the chandelier light because nobody indents better than yourself, and the use of a perfluorocarbon liquid helps a lot to stabilize the retina, so you can increase the vacuum if you need with more safely.
Perfect.
I have a question for all of you. Like, my training was with great assistants. Like, I have always an assistant with me depressing, and I have a great assistant now. Like, residents help me really well, but sometimes I'm by myself and I start training with a chandelier and indenting myself. But I don't find that the light is quite as good as someone like indenting for me and having my light pipe and the cutter in the other hand. So are you comfortable, or do you find any difference between the chandelier and like with the light pipe and someone helping you?
Yeah, sometimes I've asked my assistants to turn the chandelier light for a place or another, and making intorsion and extorsion movements in the eye, I can get visualization. Another thing you can use, it's your endo illumination outside the eye for retroillumination. You can indent it, the sclera with it, if you can improve the contrast in some places in the periphery.
Here we have as well one question from Asruval Moreno. He's asking us, what about the cutter's opening? Up or down to the yelloid?
By side. I usually tell the fellow not to turn is about the mouth of the cutter, he said? No.
Yes, the opening of the cutter, yes.
Felipe is told that. Usually tell them to go with the port of the cutter lateral, not posterior or not direct to the retina. Started to do it laterally.
I believe he refers to the setting of the machine. If you like to the duty cycle, how you manage the duty cycle when you're doing core vitrectomy or like shaving vitrectomy. So if you adjust those parameters in the machine when doing like core vitrectomy or when you're doing like the shaving of the highway.
Oh, I just adjusting in the foot pedal, trying to keep the vacuum low while I'm shaving, but I don't set the instrument differently for these two steps.
Yeah, usually I do the same as Philip. Is I use proportional, so you have the fixed high cut rate, and then the vacuum depending on your foot positions. And when you do peripheral shaving, you press down very gently so that you have minimal aspiration. You're still cutting the very high cut rate that your setup is. And then when you do a core vitrectomy, then you use the higher vacuum. So I don't have a peripheral shaving mode either. It just is, I think it's better because you have much more control with what you needed to do. And by facing the cutter opening away from the retinal surface, you minimize the risk of trauma to the retina.
Dr. Lam, what system are you using?
I also use the constellations.
Same for us.
All right, so let's move. All right, we already talked about this. So
I have a question regarding the previous. Does
Yes.
anyone of you like use any dual linear pedal for doing vitrectomies, or like do you use the linear pedal?
I have tried to use the dual linear, what they call the 3D system of the setting in the constellations. I found it a little cumbersome because the first part of the foot pedal and the last part of the foot pedal are preset in certain cut rate and certain vacuum. I like to have more control, so that's why I prefer the proportional setting rather than the 3D setting in the constellations.
And or does anyone use the Stellaris at some point, like that platform?
No.
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 Looks like Alcon has the market.
Yes, it does. So now we're moving to the next discussion point. So now I will ask you about the yalidectomy. How do you do it? If you recommend to use transinolone in all your first surgeries, or in which cases do you use it? I have here one video from Felipe. You wanna explain it?
Yes, okay. Here, the inducing posterior vitreal detachment maneuver, it's important to zoom in and get a good visualization of the op disc. So I start in the nasal edge of the op disc and aspirate the maximum vacuum and slowly move my vitrector toward the periphery. Sometimes you are able to do it in the first attempt. And for the fellows, it's really important to keep your head, that you have to illuminate your vitrector tip all the time. You think it's not just like a lamp in your house. It's just the guy from the theater that have the light and turn it and the position of it. It's important to see the vitreous. And it's important also to be aware about the periphery, so you can avoid iatrogenic breaks and another things.
I have here also another video from Uriel. You want to explain us?
Yes, I always use, almost for every case, I use triamcinolone, and for the PVD, I strongly suggest for fellow. That's my opinion. And like when you pull a PVD, like what I think is, I think about the wise ring. So I try to put like just over the optic nerve very carefully, and I start only vacuuming with the cutter off, and I stay vacuuming for a little bit, trying to make sure that a lot of gel gets into the mouth. And then I start moving very, very slowly towards one side of the retina, trying to leave for the last part, the macular side. And while I move really slow and always being conscious that the eye, it's round. So I make sure that I won't go towards the retina. So I start like moving towards one side and lifting up the cutter only with the vacuum. And if it doesn't detach in the first attempt, I just turn on the cutter, cut a little bit, and go down again, do the same thing, but to another side.
Perfect. So, Chafa, are you there? Chafa.
Yes, I'm here. I'm here.
So tell us about your experience about doing these steps in the surgery.
Well, for me personally, I don't usually use triamcinolone routinely unless it's very adherent. So for example, vitreomacular traction or younger patients, but sometimes I use dual blue to help in inducing the PVD if there's any difficulty. But I do find the triamcinolone very useful as well.
Perfect.
Just a comment about the triamcinolone. I found if you use the full strength, it is too dense. Just like the case in show, it obscures everything. You can't really see that well. So I usually dilute them to about a quarter to a third, and that makes it a little easier to see the vitreous rather than you have a big chunk in the middle, and makes it very difficult to see the different layers.
Yeah, I usually dilute it too. I find that helpful as well.
I diluted 50-50 BSS and triamcinolone because you just want that quick stain and then you want it out of the eye. So yeah.
Well, personally, I rarely use, just in like high myopes or cases that I'm really not sure that I've seen the posterior highlight. But in usual cases, it's quite hard for me not to see. So I leave this for, it depends on the surgeon, on the ability of the surgeon to see. As usual, I use in cases like reops or high myopes or different cases. But in the usual cases, I rarely use triamcinolone. It's a question of if the surgeon sees or not.
Yeah.
I mean, like a personal question. Sometimes some people, I have worked with fellows, they see easily. So I say, don't use it. So some others where it is, did I detach? Didn't I detach? So in these cases, it helps, but it's a question of leave it to the concern of the surgeon.
And for example, what do you do when you have an active bleeding while doing the vitrectomy? Increase infusion. What do you do in those cases?
Yes, I increase infusion to 60, wait 3-4 minutes, and see if it stops. Then I do it again. And in some cases, you can cauterize just if you see where you cauterize. So if there is active bleeding, cauterization is not a possibility, just after it stops. So the main thing is to increase infusion.
You can also do like a gentle pressure with the cutter on the bleeding vessel for a couple of minutes, and that will take care of it as well.
Can cauterize with endo laser also in cases of diabetic retinopathy. In small bleedings, you can just increase the duration and low power, and you do laser to control. But in more important hemorrhages, you need the endo cauter.
Dr. Lam, do you have any advice about this to regards this step of the surgery?
I do all of the above, depending the situations. Yes, all of those options are very good options.
Perfect.
I think one comment though. I mean,
yes,
a lot of these. So, for example, these are typically bad diabetics who have poor perfusion. So, I'll typically start with a lower infusion pressure. And if you do have to kick up to 60, you have to be very careful that you're not riding 60 too long and perhaps give the nerve a break every once in a while, because it's quite easy to really snuff out these nerves. And you can just kind of play around with the numbers. You can see that at anywhere 18 to 20, there might start to be pulsations, or the vessels get very thready and the nerve pale. So in those bad diabetic cases, you really want to pay attention to your infusion pressure and the appearance of the optic nerve, or else you might have a surprising 2-week post-op visit, which is otherwise, which you otherwise didn't expect.
And for example, what about when you decide to do bimanual technique? Do you have any specific case you recommended at the beginning when you decide to do a bimanual technique, like in this example, for example?
It's not an easy step for beginners, but I think it's very, very, very useful when you use a chandelier light. And in a case like this one, in a tractional diabetic retinopathy, you can hold the membranes with a hand and create the planes safely with another one. Another useful step to do bimanual techniques is in hard PVR cases. But it's difficult to the fellows in the beginning to do these maneuvers.
I think if they practice it more often, they will get more comfortable. So therefore, I think this is a perfect case. So any diabetic with tractional detachment with broad membrane and firm adhesions is a good case to use the bimanual technique, because that will avoid trauma to the retina. And the key is, if you practice it more, you get comfortable. If you only do it in the most difficult case, every time you sweat, because every time it's difficult. So do it sometimes in the easier case to just get some confidence.
I agree with all the comments.
I'm using each time less bimanual techniques since the beginning of 23 and 25G. I'm from the time of 20G. So with these small cutters, 25, I hardly use bimanual. I usually find a plane to dissect and to cut the membrane with the probe. It's not very common to me to use bimanual. Of course, it has utility, but I think with the small vitreous cutters, you will use less and less indications.
Yeah, I agree 100% with Eduardo there. And I think just taking it further with 27 gauge cutters now, I often do a hybrid 25-27 or a 23-27. And so, for example, a case like this, you can often, complete the whole case just with that 27 gauge cutter, because it has that bevel tip, and you can really get under and dissect, and so it does a really good job.
Perfect. So now let's talk about tamponates. So when you decide to put, for example, silicone oil, when to put gas.
I think it depends on the pathology, patient's particularities, surgeon preferences. It depends how long do you want this tamponade in the eye. But I think there's no rule. There's no right or wrong cases, but the indications for silicone oil for me is complex cases of trauma and pediatric retinal detachments. One more combined tractional and rhegmatogenous retinal detachment. I think it's better if you use silicone oil. In other cases, you can use SF6 or C3F8.
The first thing is to discuss with the patient, because sometimes I've done last week a case with one single break at 6 o'clock. Very, very easy case, very, easy case, 30-minute surgery. And I explained it was a 30-year-old woman. And I explained about the gas, you look down. And the first thing she said, no, I won't do it, I won't do it. So it was a very, very, very simple case, and I used silicone oil, even that I had to remove some months later. So as Felipe said, you have first to discuss with the patient if he will adopt the position, if he has on the opposite side, a 90-year-old person that has to look down, so you better use siliconoid. So for things to look at the patient, then to see, are there multiple breaks, and do you need to tamponate? It's just one break or more than one? A lot of PVR. So as Felipe said, it's talk with the patient and see what happened on the surgery.
Do any one of the panelists use PFO or perfluorocarbon as a temporary tamponade in some cases, or not?
I've never used it as a tamponade. There's a lot of some surgeons that feel comfortable to leave it a week or 10 days, but I don't have I didn't have any experience with that.
I mean, the one time I will consider that, I mean, I haven't had a case for it yet, but is if you do an autologous retinal transplant for a large MAC hole, you typically do leave them supine with PFO in the eye for up to 2 weeks after that. So that would be the one time I would use that, but I just haven't had a case for that yet. Other thing about tamponades, you also want to ask about travel. Like every once in a while, I have a patient who like has to fly somewhere, and so we end up going with oil, even though they certainly could have, they could have got away with gas. And then I had a question for the panel. So you have a superior detachment, single small tear, pretty easy case. Does anyone leave air?
I would do pneumatic. I do a lot of pneumatic.
I would do the same.
With air or with gas?
I do a lot of pneumatic retinotics.
Yeah. But in
cases
in cases of vitrectomy, I use SF6 in these cases also.
Yeah, me too. I'm not brave enough to do air, but I have read some of those papers that reported reasonable success rate with using air. So I think that's pretty interesting.
Yeah, it's a possibility, but I think I don't know.
Risky.
Always, yeah.
You have to prepare to re-inject the air.
I think there is one more scenario where I think that we will use oil is in one seeing eye patient. Like if there is only one eye, like you want a fast, quick recovery, and you probably use oil in those cases too, right?
Yeah, that's right.
Yeah.
I forget to comment it.
Another case where I consider oil for one eye, if, for example, they have bilateral detachments, like bilateral maculons or so, then I'd use oil for one eye and possibly gas for the other.
But I think by the end of the day, like I think it depends on any case. But I don't know. I think that you, Dr. Lam, like I think that you study a lot of the properties of the gases, and I think that the gas, if you read the dynamics of the gas, if you read the properties, the buoyancy, and all the characteristics of the gas is a better tamponade than oil, right? But
absolutely.
But you need to consider like each situation.
And by the time you decide to use gas, who prepares the gas? You yourself or your nurse assistant?
I prefer myself. It's
That's
really important.
Yeah.
Depends whether you trust your nurse assistants.
So the Constellation certainly can do the concentration for you. In fellowship in Philadelphia, we typically use that. In Edmonton, though, they hand us a 50 cc syringe with 100% gas, and then we always dilute it ourselves. And that's the way I prefer it. And I typically read out the numbers, down 9 to 50 or 15 to 50, just confirming the percentages as kind of a safety check before we do the exchange.
Yeah, I think I think the accessory is it's too expensive and it's not very useful.
Right, correct. Yeah.
I dilute in a 20 cc syringe. I don't use a 50 cc. And I have used the 50 cc, but I found it's exactly the same of 20. So you can try.
Yeah. Just 50 cc is easier to calculate percentage for anybody in the room. I think that's it. Yeah. And also for those people who has come see hand like me, the extra 20 cc of gas will help me at the end.
Yeah, absolutely.
Andreas?
You're mute.
Okay, guys, so that was the last discussion point. I don't know if you want to add anything. I think we have some question here. So as Raul Moreno, he's asking us what to do if you try several times at the optic disc unsuccessfully developing DVP, PVD.
And there's cases that these steps it's really difficult. Sometimes you can try to stain with brilliant blue and start a peeling of IOM, so you can reach a plane to detach the posterior vitreous, because sometimes there's a vitreous schisis. It's not the total posterior hyaloid that's present, just in some points of the retina. And then if you removing block IOM and the remaining hyaloid, it's a way to handle it with it.
The other option is that this is, you can stain it with beam blue or the triamcinolone so they can see the vitreous. And I agree, those cases usually in the setting of vitreous schisis. And I found using the diamond duster membrane scraper, scraping the vitreous towards the disc so that you get accumulated vitreous, so that you can actually then either use the forceps or the cutter to elevate the hyaloid and detach it. But those cases are difficult because the vitreous that is adherence to the retinal surface are often quite thin, and they are not that easily grabbed with the cutter. So sometimes using the diamond duster scraper and the forceps are helpful.
Or even the flex loop. You can use the flex loop for this type of.
Yeah.
But as a conclusion, never give up, right? Like you don't want to leave it.
No, it's
down below, right?
It's a key point
keep pulling, keep trying, and stay there for a little bit, right?
Yeah.
It's the personality of the retina surgeon that will not give up.
No, can leave it at that.
And you know, another maybe tip for avoiding the difficult induction is, you know, don't do so much core. You know, maybe do a little core, do a little stain with triamcinolone, just so you don't debulk everything, so you have something to really go to and bite onto at the nerve. If you do too much because you maybe thought the hyaloid was already up and then turns out the hyaloid's down, yeah, then you have less to play with, and that can make it a little more challenging. So go to it sooner than later and get that step done.
Guys, I want to thank you so much for your time. I think it was amazing. There was a lot of skill transfer and a lot of knowledge for any surgeon who is beginning in retina surgery. I do believe that simulation, not only with virtual simulation, but with artificial eyes and the correct methodology, can be a game changer. Maybe you agree with that. And well, we hope to have you next time. Right, Andreas? Thank you so much for organizing this amazing event.
Our pleasure. So thank you so much, Felipe, Eduardo, Dave,
thank you, everybody.
Uriel, Shafa, Alexander, Dr. Lam. Was amazing. So hope to see you guys soon.
Thank you very much. Good night to everybody.
Thank you so much.
Have a great day. And a good day.
Yeah,
Good day, good evening, good day. Good night.